staff launch event. So we just thought we'd put a bit of a presentation together about sort of what's how the service has developed and where the sort of thinking has come behind the service, and then kind of just a bit about what we're doing at the moment, so that people know and can ask questions and pick up information that we've got here. So just to start thinking about palliative care and what we mean by palliative care, I've got a definition up here. And this is from Marie Curie, and then the other part of the definition is from the World Health Organization. So it's just thinking about actually what do we mean by palliative care, so that we can be appropriate with the referrals and also appropriate with the support and the service that we're providing. So a support system to help patients live as actively as possible until death. So that sort of reflects Dame Cecily Saunders, who was one of the founders of palliative care and hospice care. And also thinking about an approach that improves quality of life, facing problems with life-threatening illness, prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other symptoms, for example, breathlessness, fatigue, nausea and vomiting. Those are some of the common ones that we see, as well as sort of maybe physical changes, but also it's highlighting there in the green at the bottom the kind of impact of psychosocial and spiritual aspects. So we really are looking at that holistic assessment of a person, not just focusing solely on the maybe physical symptoms of their condition. So obviously that's a bit about palliative care. Now, I'm an occupational therapist, and our service is run by occupational therapy and physiotherapy. So we're looking at palliative care from a maybe slightly different angle to maybe nurses and doctors. So we're looking at rehabilitation. So I always think it's nice to maybe think about how palliative care and rehabilitation can go together, because some people maybe feel that they can be a bit of a, conflicting sort of paradigm. But with rehab, this is a definition that's from the NHS England 2016 documentation about commissioning of rehabilitation services. And the NHS have put things in place to say that they feel that rehab should be part of every patient's journey in whatever condition and throughout their life course. So again, rehab is a personalised, interactive and collaborative process reflecting the whole person. So linking that back to our palliative care definition, it's holistic. And we're enabling the individual to maximise their potential and live a full and active life. And that was reflected in that palliative care definition. And we highlight the word habilitation as well, because a lot of rehabilitation is always talking about recovery and returning to the level of function that somebody had before their illness or injury. But with lots of long-term conditions, and certainly with palliative care, that's not necessarily a realistic aspiration. We're not necessarily going to be able to return the person to their previous level of function. So habilitation is the idea of actually somebody coping with their current level of function and making the most of their abilities and doing the things that they want to do at their current level of function. So I quite like that word. In some research that came out in 2015 alongside a document that I'll speak about in a minute, there was a lot of evidence to show that patients' fear of functional deterioration was actually a bigger concern and worry for them than the actual fear of dying. So we know that actually people's function and independence is really important to them, and certainly physiotherapy and occupational therapy have done a lot of work into these things recently, and there's a big campaign from the College of Occupational Therapy about living, not existing. So people with long-term conditions should be able to live, not just exist with their condition. And I also like the quote of "Don't stop dancing because you grow old because you stop dancing." So that works for me. So why we need to think about maybe rehabilitation within palliative care is we know that these things are impacting on healthcare in general. So increased disability and comorbidities, more people living longer with more, multiple conditions. We know that there's an increased number of deaths over the years, and we know that our population is getting older. So all of these things impact on the health of the population and therefore what services they need. Health and social services don't have any more money, as we all know, so we're all trying to do the same, more care, more support with the same pot. So actually, if we can help people to maximise their independence and maintain their function and self-manage their conditions, we're more likely to be able to provide more services for people. We also know that there's going to be a big increase in dependence on carers, and we know that people are living longer. Therefore, people are older when they're looking after maybe parents that are ageing and have medical health problems, but also maybe looking after younger people as well at the same time. So, carers might still be working while they're trying to look after somebody with an illness, as well as having something, maybe a condition themselves. So we know that health and social care is having to change. So thinking about all of this, in 2015 there was a document that came out from Hospice UK about rehabilitative palliative care. So with some of those things that I've talked about, thinking about maximising people's quality of life and really focusing on their priorities and their wishes while they're receiving palliative care. Helping people to optimise their abilities, making sure they can actively manage their own condition, not having to rely on services as much, being able to be out there and live their lives as fully as possible in their own families with their own social support, and only needing services, intermittently. Patients and loved ones having choice and autonomy, so really that encompassing and inclusion of the carers within the patient's care. People being able to have meaningful participation in activities and relationships. So I suppose maybe stepping away from some of that medical model that's been the kind of centre of lots of care recently, and thinking about a holistic and multidisciplinary approach. So this document, Rehabilitative Palliative Care, came out in 2015, and the charity here at Cynthia Spencer read it and felt that it would be a positive thing to be able to implement here. And we felt that actually what was the day hospice, so what this part of the building was used for, would be the best place to really start embedding this practice. They felt that it could be expanded, the service that was provided here, and look to be more rehabilitative and offer more of a variety of a service. So investment was put in from the charity, and we now are running an occupational therapy and physiotherapy-led wellbeing service here. So we've dropped the word hospice from our part of the service to try and break down barriers for people. We've gone from being open only 2 days a week to being open 5 days a week. So we're still Monday to Friday service at the moment. At the moment we're offering 10 different sessions, so we've increased the variety. It was previously just 2-day sessions. We try and have one-to-ones with all of our patients with a therapist to help identify sort of individual goals, needs, and try and book people into appropriate sort of sessions. So trying to be more individualised with the patient care than previously was happening. And we're kind of constantly reviewing everything and getting lots of patient and carer feedback to be able to progress and develop more services and more sessions that can be on offer. We are using assessments and outcome measures here. We're kind of still in the early phases of trialling some of these things and working out whether they fit our patient population. The IPOS is the Integrated Palliative Care Outcome Scale, and that's something that's being used across the services in specialist palliative care. And it's a self-rating scale, so the patients can rate themselves, and then we can flag up and really focus on the most key issues for them. So that's been helpful. And then the others are, so timed up and go and modified functional reach. We're using those as part of our exercise programmes to ascertain whether the exercise and the programmes have been effective, and that's kind of still ongoing, a bit of work from our point of view. And then goal setting, we're using goal setting to, as I said, identify patients' wishes, their priorities, and then try and individualise their programmes of care. So quite a bit of criteria. I've got sheets that have the full criteria on them. So our criteria mainly is about we're a service for adults, so over the age of 18, patients with a life-limiting condition, so that might be an advanced cancer, it might be a rapidly progressive neurological condition, advanced respiratory or cardiovascular condition. Then there's probably others, but again it would be about individually discussing that per person. The other things there are probably fairly self-explanatory. We are a community setting, so people need to be stable enough to attend and generally be able to move around the room with either a minimal assistance or to be independent. There's a few more details on the criteria list that we have, but what we always say is if someone's got a question about somebody, to contact us, give us a ring and we can discuss it. We're trying to be as open as possible. A few things that we can't manage, as I said, we're a community setting, so anybody that was acutely deteriorating would be quite difficult for us to manage. We don't have medical or nursing input on a day-to-day basis. Again, manual handling needs. If anybody had a significant cognitive impairment or behavioural needs, we would struggle in the environment that we have and with the staffing that we have. But again, we could maybe offer some advice to the carers or people that are supporting that person. The same with nursing and residential homes, we can maybe offer them certain sessions, but maybe not other sessions, depending on what their needs are. So we've got a copy of our timetables out on the tables at the back, so please feel free to take one. It is a sample timetable, so we do adjust sessions and move things around depending on patient numbers and staffing numbers, etc. But it gives you an idea really that we're trying to sort of have variety through the week so that people can access things at a time that would suit them. We get a lot of requests for everything to be in the afternoon, so it's just a bit of a balance about how we can sort of spread things out over the week. So I'll just quickly go over our programmes, but are there any questions at this point from anybody?
Are the sessions free? Or do the patients have to kind of pay a contribution towards?
It's all free, so it's all jointly funded between the NHS and the charity funding, so all the sessions are free. I'll come on to a little bit of housekeeping about some of the transport as well, but we try and keep everything free to access as much as possible. Thank you. So, in terms of our exercise groups, we have 3 different exercise groups now at the moment. So our lowest level of exercise group is seated Tai Chi. So obviously that is really accessible for lots of different people with lots of different conditions. It's lots of upper limb movements and some lower limb movements, but all from a seated position. So anybody with balance problems or struggles to transfer could still take part in that exercise. There's lots of sort of breathing control and mindfulness and meditation, so it's also a very relaxing session, so really good for people that may be finding that stress or anxiety is a big problem for them as well. So yeah, we've been running seated Tai Chi since the beginning of this year, and we've had some really good feedback from patients who've really enjoyed it. We do a walking group, so that's every Monday at 11 o'clock. It's a drop-in, so that can be anybody really. If people want to come and find out more about the service, they'd be welcome. Patients, carers, relatives, anybody that would find it helpful. We know that people often enjoy walking or enjoy exercise, but maybe struggle with the confidence to go out and join a community group that maybe walks locally to them. So our walking group, we have a variety of lengths of walk that people can take. We use our hospice gardens and the grounds here, lots of seating areas, plenty of places for people to rest. Or if people are a little bit more fitter and more active, they can use the local parks, and that can be up to sort of a 45-minute walk. But again, it can be at a nice slow pace, supported by staff and volunteers. So it's really supportive for anybody that maybe has mobility aids, uses oxygen or anything like that. We'll let the person in, but that's fine. So our walking group's really good, drop in and everybody's invited. We then have a gym group, so this is our highest level of exercise. So we have a small therapy room over the other side of the hospice, and Hi Jenny, you're right. Yeah, we have a small therapy room over the other side of the hospice that has some bits of equipment, and it's a Gym Buddies is a group run by our physiotherapy colleagues and rehab assistants. So it's all about individualised supported gym exercises. So again, really helping people to maybe get back into doing something that they've maybe lost during their diagnosis and things. And being able to work on specific goals. Somebody wanted to be able to climb the stairs, so we did lots of work to help them get back to doing that. So you know, it's been really positive, the gym, and I think so far we've had 100% of people have achieved their goals that they set out at the beginning, so that's really positive. So from an education point of view, we run our 12-week information programme. We've got the topics list that if anybody wants to have a look at it, but that's everything from, we talk about things like falls prevention, we talk about advanced care planning, we talk about fatigue management, the role of physical activity. We also have some of the sort of hospice services, so our chaplain comes in and talks to people about their service, and we also sort of look at complementary therapy and things like that. So a variety of things to be able to support people's general well-being. And over the 12 weeks, we can kind of get to know individuals and guide some of that information sort of specifically to them.
Is that kind of group therapy?
Yeah, so it's a group, normally about maybe up to about 10 patients would be the maximum really. But
we'll get the all nice relationships.
yeah, and it's lots of discussion and it's very informal. We don't sort of stand up and preach at people. It's very much about a discussion, and people actually tend to learn most from each other than necessarily from us at all. So yeah, lots of time for that sort of social support as well. We run fatigue management, so we can do that either in a group or we can do it individually. So our groups again might only be a small group, so often sort of maybe 4 or 5 people. So we can really talk about individual activities that people are doing. We ask them to complete fatigue diaries so that we can sort of really kind of look at what their week looks like, and then sort of make some more changes. Do sit down, Jenny. Come in.
I didn't want to walk in front of the camera.
It's only me that's filming. So yeah, so fatigue management, we kind of go over things about why somebody might be feeling fatigued, what their triggering factors might be, and then we look at behavioural and sort of day-to-day modifications that they can make to their activities to try and help them manage that, as well as things like exercise, diet and sleep, you know, those topics as well. And we'll normally do those, if we do it as a group, we'll do it maybe over 4 or 5 sessions. If we do it individually, it will just be dependent on that person really. And then the same, we have a Breathing for Wellbeing programme that we generally do over 5 weeks with a group of patients, and that can be people that have got a respiratory diagnosis, or it can be people that just find breathlessness as an issue for them as a symptom. And again, we look at what might be causing their breathlessness. We then cover things like using fans as a therapy, different breathing techniques that people might find beneficial, and also talking about the interplay of like anxiety with breathlessness, because we know that that's you know a big area for a lot of people, is how their breathlessness causes anxiety, or when they're anxious they become breathless. So we do quite a bit of work on that with some groups as well. We then have our enjoyment afternoons, which are probably more of our similar, you know, more traditional model of a day hospice, but we kind of have adapted them slightly, changing the times and changing the setup as well, so that we're providing those opportunities for people to participate in leisure activities, doing things that maybe they've sort of not been able to do, they can't access themselves anymore, but also that peer support and social interaction that a lot of people have lost because their worlds become so small if they're not able to get out of the house on their own. So everyone comes in and meets here. They have lunch as a group, which can often help with people that are maybe have got a low appetite or aren't eating very well, especially if they live on their own. People tend to eat quite well when they're in a group here. We do some relaxation, again as a group, and sometimes it's guided, sometimes it's just music or something like that, depending on what the group might prefer. We then in the afternoons will do a variety of different activities. We have volunteers that support. We have some complementary therapy available on those days. And as I said again, lots of time for that peer support and social interaction. It's also an option for people to then be able to work on very individual goals for themselves. If somebody wanted to get out and walk in the garden, or do some gardening, or maybe take part in a specific art and craft activity, but they needed support, then either staff or volunteers can support them to do that. So we've had all sorts of things over the time, but we try and guide it to the people that are coming to those groups and what they would most benefit from. And then the last sort of main session that we're running at the moment is our Wellbeing drop-in, and this is in conjunction with Northamptonshire Carers. So for patients, they're invited to drop in. They can find out about wellbeing and specialist palliative care. Staff are available to discuss the programmes, gives people an opportunity to come and see the room, see where we're based, find out it's maybe not as scary as they think, that coming to a hospice isn't all doom and gloom and that we're quite nice. They can pick up information leaflets, but then they can also bring their family or friend or carer along for some support. So the Family and Friends Support Group is run by a representative from Northamptonshire Carers. The family and friends will come in and then they will go off into a separate room. So they can have that individual support, and it's practical support from Northamptonshire Carers, but also that opportunity to talk openly and freely, not necessarily in front of their loved one, because often there's that kind of maybe interplay of both sides of the of the couple or whatever, not maybe mentioning everything that they want to ask, or somebody might want to talk about the future whereas the other person doesn't want to talk about the future. So it's that opportunity to sort of be separate and have individualised kind of carer support. They can obviously still find out about specialist palliative care and the wellbeing service. And also this was part of the feedback from carers of maybe people with neurological conditions that felt that they weren't able to leave the person that they were caring for at home to be able to come here to access the support from Northamptonshire Carers. So the idea is that they could bring their loved one here, and we can help support them while the carer gets some support in a separate room as well. So it's to try and make it as open as possible really, to both prospective new patients, current patients, but also the friends and family that are supporting those people. So we've been running this since the beginning of this year, and from September we're going to make it twice a month, because we think that there's actually more need for people to have it a bit more regularly. So that's all drop-in, nobody has to have a referral, and people can come and access it as and when they require. From September we'll also be running a heart failure programme. So this was in conjunction with the heart failure nurse for Northamptonshire. For the other half of the county, Lakelands in Corby provide a heart failure group, but there was nothing sort of for Northampton and this area. So we've planned a programme that's going to be starting in September. It's going to be an 8-week programme of information, so education about heart failure, about symptom management for heart failure, and also looking at sort of physical activity and exercise, and relaxation and managing of sort of symptoms. So that will be joint between ourselves and the heart failure nurse, and it will be kind of a pilot in September, and then hopefully progress to being a regular programme that we put on. So there's information about that on the table, and if anybody has any referrals for that, then they can chat to us as well. So that's kind of an overview of our programmes. The only other things to say really about the housekeeping is about the transport. So I know you said about do people have to pay. So again, our transport is free. It's volunteer drivers that we use to help transport people here. So the volunteer drivers use their own cars. They have some very minimal training in manual handling. So as long as the person only needs sort of minimal assistance to transfer, our volunteer drivers can support them. If they needed more manual handling needs, or things were more complicated, we can potentially sometimes use wheelchair taxis, but really we're quite limited on the rest of the transport available. So we do always ask in the first instance if patients can arrange their own transport here, and then we keep our volunteer drivers for people that aren't able to get here themselves, but it is a free service that we provide. As I said before, patients need to bring their own medications with them. As we're a community service, we don't hold a stock of medications, and as OTs and physios, none of us are prescribers or advise on sort of prescriptions. We would go to our medical and nursing colleagues for that. We do often share patients between ourselves here in Wellbeing and maybe the doctors or the nurses within the rest of specialist palliative care. So we will sort of share patients, or we'll ask advice if we need any. And with most of our sessions, we welcome people to bring their family and friends. We think that especially with the education, there's often a need for the family members to be involved or to hear the information as well. But in terms of our enjoyment afternoons, we try and keep that to patients only, because we think, you know, in terms of the room, it can get quite full quite quickly, and also that time often to be apart from their loved one. You know, sometimes people need a bit of space actually. But we will discuss it on a one-to-one basis if there are sort of specific care needs or sometimes communication needs. We'll sort of be quite flexible with that. So that's kind of where we're at the moment. In the future, we're hoping to develop further specific groups. So obviously I've mentioned the heart failure group. We're also looking into a motor neuron disease group, so sort of more condition specific. So you know, we might look at those further in the future as well. We want to look at more exercise groups maybe in the future, as well as looking at social prescribing of activity. So with the Tai Chi, we want people to try and, you know, do the Tai Chi group with us, build their confidence, but then maybe go and access a community group if they're able to. So we want to help people to be able to go out to those groups, maybe have a supported couple of sessions, and then leave them with that community group so that they continue their kind of gaining of those sort of physical sort of benefits of the activity, but also the social benefits, but out in the community rather than being linked to a healthcare environment. We're looking to develop a specific anxiety management programme, and hopefully that will be up and running in the kind of autumn time this year. And again, that will be open to anybody with any diagnosis, but with a specific need for maybe anxiety or sort of management or sort of that type of thing. We're going to continue our use of outcome measures and carry on developing what works well for our patient group really. And continue to work with Northamptonshire carers. As I said, we're going to try and increase the drop-in to twice a month from September, so that there's more capacity there, especially with our client group. We know that timing is everything, and actually when people need the support, they need it timely rather than necessarily waiting a whole month to be able to access it. Any other questions at this point?
Got a very pernickety question.
Yeah, no, that's fine. That's absolutely fine.
Where do you stand on mobility scooters? Are you happy?
Yeah, so we do have people that come in with mobility scooters. It's always just a little bit about like space and everything like that, but we do have a few people that come in mobility scooters. If it's a nice sunny day, they often will leave them outside the front access door, but otherwise people can park them in here or on the corridor as long as they're not blocking any fire escapes really.
Okay, and then would they be allowed to kind of sit on them all the time, or would it kind of just be parking?
Normally it's parked.
Yeah.
Normally they're parked, and then people will access the room sort of without them. If they electric powered wheelchairs, we have got some people that spend most of the session within an electric powered wheelchair, so we can accommodate that. We just need to know about it and obviously adjust group sizes and group numbers. If we have a powered wheelchair, it takes up space, therefore we just need to be aware, you know, in terms of with the other group members. So we try and be fairly flexible on those type of things, but it'd probably be an individual person to person. Things like in our gym, we couldn't really accommodate that. So those gym groups are generally for people that are mobile with minimal aids.
Yeah, no, I was just thinking more so of the activity groups and
Yeah,
things like that rather than the gym sessions.
Yeah. So, you know, we try and be as flexible as we can. Thank you. Any other questions? Okay. Thank you very much for coming and for listening, everybody. So there's lots of information out on the table. So there's loads of information leaflets, and there's our criteria, referral form, etc. So please help yourselves, and also drinks and muffins. Please help yourselves. Thank you very much for listening to me.
Thank you. Nice, well done, Mel.